Welcome to Modern Management of the Older Adult, brought to you by the Institute of Clinical Excellence.
Hello, everybody, and welcome to the PT on Ice Daily Show. Christina Prevett here. I am our lead faculty and division lead for our pelvic and our geriatric older adult divisions. And today I wanted to talk to you about being old school. If you have been to our older adult live course, you know that we talk about being old school and talk a little bit about ageism within the workplace. But that's not kind of where I'm going with this. You all know that when we are working with other people who have different experience levels, different ideologies, that we can sometimes talk particularly about our physicians about being old school. And what that means is doing things like we had done previously, even though there is different evidence and different protocols that have come up in the interim that are considered to be newer, more novel, or more evidence-informed. And so today I wanted to talk a little bit about, is that a problem and is that harmful? And give a couple of examples, one that we see in medicine and one that we see in rehabilitation. So firstly, I want to say that when we are talking about being old school, we are not talking about trying to discriminate against individuals who have been in the field for a long time. As I mentioned, we talk about ageism in the workplace and how sometimes our systems, our administrations, and even sometimes us as physical therapists tend to gravitate towards our newer grads as being most up to date with the evidence and can sometimes dismiss the experience of our veteran clinicians. And this can create some problems, right? Like we can say, oh, they're just old school and dismiss some of their experience and the methods and the ways that they have evolved in their own practice over time and kind of dismiss those ideologies as being outdated. And we don't want to talk about that, right? We don't want to talk about how we see this ageism come into the workplace. And I always say, like, we have very different types of clinicians, and it is specific to the person, not specific to their age, right? We have some clinicians who have practiced for a year and they have repeated that year 20 times, and we have people with 20 years experience. And what I mean by that is that the age at which, or the number of years that you've been practicing, accumulates some clinical experience, obviously, but we want to be matching that with staying evidence informed. And when we have those years of clinical experience, but we don't ever evolve or change our practice, that can be problematic. And that is when old school takes on a negative connotation. And oftentimes we don't see that as something inherently bad, but we see it as a difference in practice. And where I want to come today is to talk about, really this is older adult specific, but it is kind of therapy specific, where we need to be thinking about how staying up to date with the evidence is a way for us to reduce harm. And sometimes being old school or not staying up to date with the evidence can actually be harmful. So I want to give, first of all, an example that we see in medicine. So we have surgeons who are going to take different approaches for a variety of different orthopedic conditions. And one of them is a hip replacement. Okay, so with a total joint, total hip arthroplasty, we have an anterior lateral, or posterior approach to that surgery, right? We have those three approaches. And depending on which approach the surgeon takes, depending on their kind of ideologies and thought processes, the amount of precautions that they are going to give and the type of precautions and the length of that precaution is going to be highly variable. Now, I will say my bias is that we have systematic reviews going back from 2015 that our hip precautions placed on rehab have no evidence to support them with respect to reducing rates of dislocations. Here's what we do have evidence for. So the two biggest factors outside of having somebody with low muscle mass that falls within the first 24 to 48 hours is a posterior approach and an improper fit of the cemented component of the arthroplasty. So when we have that evidence, right, what we need to think is that we should be moving away quite readily from a posterior approach and promoting an anterior anterolateral approach and removing precautions. And we are seeing that in some regards, and we are not seeing it in others. And so what we are seeing is that those who continue to use a posterior approach are being very, very fickle and sometimes very conservative with their precautions in a way to try and minimize the downstream consequences or the potential increased risk of dislocations. And in that case, being old school is dangerous. And where I get upset as a rehabilitation provider is that they have essentially passed the buck off where there is an elevated risk and they're using our rehab as a way to try and reduce that risk. But again, our evidence does not support the use of those precautions. Right? And so when we're thinking about the downstream consequences, yeah, it's going to cause harm. We are using an approach that has an elevated amount of risk. We are then placing contraindications and conservative movement restrictions on individuals that are not clinically indicated. And the downstream consequences of that are that individuals are afraid to move. And so oftentimes in our evidence, or in our healthcare system, we think about that person's point of care. We think about the time that they are under the roof of the hospital. We think about maybe their follow-ups within surgery, but we don't think about the downstream consequences of that conservative management and how damaging that can be to a person's sense of freedom of movement, right? So we took an approach that we know has an elevated risk for dislocation. We slapped precautions on them that we also know do not do anything to reduce the risk of dislocations. And actually what they do is increase fear of movement. And then we have sent them on their way and said, please don't be afraid to move, but also please don't dislocate your hip. And oh my goodness, don't fall, because that joint that I've cemented with a Black & Decker into your hip, that's going to just pop right out. Right? And so in those cases, yes, it can be problematic for us to not stay up to date with the evidence. And we have to think about, so much of our thoughts about our circle of influence or our circle of responsibility is kind of in that one-on-one interaction with individuals. But it's so much more than that, right? It's so much more than that, because every time individuals interact with medicine, they begin to become afraid because they're seeking care because something is wrong. And our response to that is often to take things away. So then how do we see this in our medical providers or in our rehabilitation providers, right? It's so easy for us to judge very harshly to our medical providers, and I hold them, right, to that same responsibility that I hold you all as rehabilitation professionals in our courses to reflect on your practice, see where we are going with our practice, and make sure that we are staying evidence informed, right? And so I'm going to be advocating back to my surgeons and saying, hey, these precautions are not what is going to reduce our risk, right? That's not it. And I do not want to cause fear. But then where we as rehabilitation providers have to be reflective of our own practice is, are we doing enough from an exercise intervention perspective to actually drive changes in muscular strength and function, right? Is our time being used diligently within collaboration with our client, what their desires are, what their current thresholds are, what their barriers, their easing factors, their facilitators, their aggravating factors to drive musculoskeletal rehab. And last time I was on the podcast, I was talking about our falls prevention and how we cannot slap static solutions onto our dynamic problems. And so we need to stay evidence informed and also bring in our clinical context so that we don't get into the ruts of our exercise interventions that are going to make us old school, right? Where our evidence is now. If we kind of take a step back and we look, and I'm going to say this about geriatric rehab, but I'm going to talk about this in general, is that our manual therapy is a short-term pain modulator, right? You're not going to hear any faculty at ICE think that we are doing permanent tissue change with whatever modality we are talking about: cupping, mobilization, soft tissue release, manipulation, traction, dry needling. Anything that we do is a short-term pain modulator, right? I'm not going to say that I'm going to massage your shoulder and I'm going to heal it. I am going to help its pain in the short term so that where our bulk of our evidence for long-term changes of outcomes is building strength and resiliency around the joint that is injured, building strength and resiliency around the system that is seeing a decline in functional reserve because of low-grade inflammation attacking the tissues, causing chronic disease, causing inactivity, causing aging physiology to accelerate, right? We need to move into exercise and resiliency building as quickly as possible. And so, saying that, we just have this old school mentality around exercise is insufficient, right? I can have 10 years of clinical experience, which I do. And I can also say that I have changed my mind on a freaking lot about exercise in both directions, right? I've been in my early career where I probably did underdose people because I was afraid, like the fear of God came into me to do no harm when I was in PT school. I swung the other way with my PhD saying like, we really need to get individuals stronger and it's really important. And now I've kind of come into the middle because I know all of our evidence around people's emotional response to exercise, very real experiences, the biopsychosocial considerations, going more into that psychosocial lens and recognizing that sometimes my exercise intervention is the least important thing that I do for that person that day, and holding space for them, for example, to grieve the diagnosis of a chronic disease that they were not expecting is the best thing that I can do for that person. And so as most pendulum slings within rehab, right, posture police versus form and function don't matter. The answer is usually somewhere in the middle, but the answer is evolving with the evidence. So no, being a veteran clinician is absolutely not a problem. However, dismissing the evidence, saying that we're old school or saying that we're stuck in our ways or that we will not evolve our practices as new evidence comes in, that is problematic, right? It is highly ego driven, right? We feel very uncomfortable being new learners, right? And recognizing that there are things that we did before that probably didn't serve our clients as well as what we are doing now, right? And that is just the evolution of a clinician, right? That is just how we are in the evolution of our science and the evolution of our research base. But it is super important that we take reflective practice. And it does not matter if you have been in practice for 6 months or 25 years. That combination is so epically important. And when we fail to do that, the person that gets hurt is our patient. And it is a largely ego-driven problem. And we need to be mindful of our practice. Reflective clinicians are better clinicians. And looking at our practice, looking at what we are doing, looking at where the evidence is, trying to stay on top of the evidence, and recognizing even checking things that are biased, like that are bias checks, are super important. Are we going to get it right all the time? No. But to say that we are rigid, that we have no capacity to learn, that we are just stuck in our ways is not fair. And for us to just dismiss a clinician who says that without trying to advocate, assuming that they are a stone wall that is impenetrable and will not move, is also not helping our clients. And so, yeah, if I'm kind of talking to a clinician that I know has kind of had that ideology of like being old school, do I get butterflies in my stomach? Do I have to be very mindful about the way I approach conversations? Of course. But am I going to avoid them, assuming that they have no capacity to change or move? No. Does it always move the needle? Absolutely not. But I definitely know that after those conversations, at least some reflection is being had. It may not cause a person to change their behaviors just yet, but consistently having conversations and being open and collaborative is definitely going to start moving the needle. All right, that is all I have for you all today. If you guys are looking to stay up to date with the evidence, I highly suggest you get on to our MMOA Digest email. That is an email that comes out every 2 weeks that shows the new evidence coming out within geriatric practice across a variety of settings. It comes out every second Friday. I am putting it together today for this week. So jump onto that. You can get into it through the app. If you are looking to get some of that evidence packaged in a nice, clean way, we go into a lot of research that has clinical relevancy, I promise, in our level 1 and level 2 courses. Our next older adult level 1 starts March 17th, so in about a week and a half. And then our level 2, if you have taken level 1, the next one starts May 15th. We do not offer that as many times per year because there is a prereq, but I highly encourage you to come into those courses if you feel like you're in a rut and that you need to kind of be checking in with your biases and your belief systems. All right. Have a great week, everybody. I hope you all are seeing some warmer weather. I know we are up here in Ontario and I am so here for it. It was also light at 6:00 last night. And again, super pumped. Have a great rest of your week and we'll talk to you all next time.
Thank you for listening to the MMOA podcast. If you found this helpful, please share with someone that could benefit. And if you're looking for more practical content to help you better serve older adults, head over to www.mmoa.online, where you can learn more about our free resources, our community, continuing education courses, and our certification. Once again, that's www.mmoa.online. Thanks for listening.